Yeah, I'm trying to do a sharp so I can see what I need to see and show you guys, but it's not saying the specific thing. And when I do extend, it's not really extending like it's supposed to. So, all right. Some of you already got to see this. The AP chest is seated or supine. In this case, you guys will show me a supine, right? A lot of times this is a modified view because the patient is too ill to sit up or stand. Again, same things apply. You're 1.5 to 2 inches above the relaxed shoulders. You're centered at the MSP. If the patient condition permits, place the elbows, pronate the hands and place hands on hips to draw the scapula laterally, right? Adjust shoulders into same transverse plane. I don't know how many patients I've had that maybe can't even do that if they're so ill. I gotta do them on the table. The central ray is perpendicular to the long axis of the sternum, centered of the IR, and you're 3 inches below that jugular notch. Yes, ma'am.
Can you explain the perpendicular again?
Sure. So your central ray, right, what comes out of the tube, is perpendicular to the center of the IR. So that bucky. Okay. So right. Here's the bucky. Here's your central ray.
Okay.
Okay. That makes it perpendicular.
Okay. So when
There. So this makes a what angle?
the right angle.
Right. That's why when we first started in lab, it was like, what is a chest X-ray shot at? 90 degrees. Right. This is going to be noisy. It's going to keep popping up in all of our pictures. And exposure is made after second full inspiration. Everybody understand what second full inspiration is?
Yes.
Okay. April, second full inspiration, what's that mean to you? Very good. Okay. Structures that you need to see. Obviously both lungs, right? The heart and the great vessels are magnified. The lung fields appear shorter because they're laying down. The clavicles project higher, and the ribs appear more horizontal. Okay? This kind of gives it a flattened effect. You do a supine portable, this is going to look very similar. Okay? And what some of you experienced in lab is that the distance is supposed to be 72, but a lot of times your limitation on your machine will not allow you to go to a full 72. The best that most tubes will get, I'm going to guess, is anywhere from 60 to 65. Okay. Some criteria that you need to think about when evaluating images are, can you see the entire lung fields? There's no rotation. Do you remember how I showed you about rotation on the clavicles and the sternum? Right? You can kind of see that space right there and whether it looks rotated or not. The trachea is visible in the midline. There's equal distance from the vertebral column to the lateral borders of the ribs on each side. The clavicles lie more horizontal than the PA because the patient is, right? The patient is not a flat object. They're round in the thoracic cavity. So it's going to make the clavicles look a little different when they're lying down. Approximately 1 inch of the pulmonary apice is seen superior to the clavicles. So you can't cut off. If you're doing a really great job of collimating, you might collimate so much that you get off here, right? You're cutting off those apices at the top. You want to make sure this is equidistant right here. You can see the trachea. You can see the heart shadow. You can see the aortic arch right here. Okay? The pleural vascular markings are visible. Remember we talked a little bit about the spider web looking things in the lungs. So this is the difference between a erect and supine position. Which one do you think is supine? The left one. Why do you say that? What's going on with this guy on the right? Can you guys identify it?
Wearing something.
No, I don't think he's wearing anything.
Fluid?
Yeah, where's the fluid?
In his right lung.
In his right lung. Everybody hear what Emily said up here?
Yeah.
Fluid in the right lung. Thank God there's a marker so I can tell you that that's the right. Because the guy on the left doesn't have a marker. Well, air is black on a chest x-ray. Fluid looks white. Here's one of my least favorite. This is the Linda Bloom. I can't ever say this one. It's all of it. Everybody calls it the lordotic position, just FYI. You're only going to need to know that term right there, Lindblom, for your registry. Linda Bloom.
So they don't call it the lordotic on the registry?
I mean, they will,
Yeah.
but you might.
Walk back and forth.
Yeah. But everybody calls it lordotic. The patient is upright facing the tube, approximately 1 foot in front of the grid, and the top of the IR is 3 inches above the shoulders. Okay, so notice that you got a little bit more above the shoulders on this projection. The part is positioned, the MSP is centered to the midline of the grid. See how it's got that target right on his chest, the middle of his chest there? You have to assist the patient to lean backwards until the shoulders rest on the grid. This kid is probably not even on a stool. What I would suggest, a lot of stools have wheels. This is the best thing to use and utilize your sandbags, is put them on a stool, scoot them forward, lean them back just a little bit so they've got this position, but they still feel secure, and put sandbags in front of those wheels, right? Because I don't know anybody over the age of probably 50 that would be able to do this position very easily, for very long anyway. The coronal plane of the thorax is 15 to 20 degrees from the vertical. Okay? The central ray is still perpendicular. There's no angle on your tube whatsoever. It enters at the MSP at the mid-sternum, about 3 to 4 inches below the jugular notch. So it's very similar to that AP projection for centering. And again, you still want to do the 2 full inspirations. So what this really shows is the lung apices and the interlobular effusions. So a lot of times TB can settle up in the apices as well. You might get this for tuberculosis on. Some people, my granny was one of them, for some reason she would get pneumonia about every 6 months. She had horrible pulmonary issues from her dad being a smoker, and she would get pneumonia, and the pneumonia wouldn't settle down low, it would always be up high. So God bless those x-ray techs. I don't know how they got her to do that for you, but they did. The entire apices, an appropriate portion of the lungs, is some of the evaluation criteria, as well as the clavicles located superior to the apices. So notice how this looks different. Where's your clavicles now? They're not down in the lung field, there's above them, right? Everybody see that at the top of the image there? The sternal ends of the clavicles are equidistant from the vertebral clavicle. So even though you're throwing those clavicles up, they still want to be equidistant. You don't want any rotation.
Those are very similar.
And this is not a perfect picture by any means, because you're still clipping some lung. But if you're just doing this for the apices and say they've already done a PA or lateral, a lot of times the tech would send something like this through because there's other images to show the rest of the lung field.
And that would be acceptable, ma'am, even though it's clipped?
In the clinical setting, yes. The clavicles are lying horizontal with their sternal ends overlapping over the first or second ribs. The ribs are distorted with their anterior and posterior portions superimposed, right? So it gives the appearance of the ribs looking a little weird, elongated. So your essential projections, the decube is one of them. So you have AP or PA projection, so it's a right or left lateral decube position. You're in a lateral projection, so it's either ventral or dorsal decube positions is another way to phrase that. And you're using a 14x17 cassette. Anything above this means you're not doing what you're supposed to, right? Don't leave it all the way open. So, here is an example of an AP projection. The patient is lateral decube on their right side or left side. To demonstrate fluid, the patient should lie on the affected side. We had this question come up in lab. Affected side is the side that we're looking for, right? So if they're saying, we think this patient has fluid in their right lungs, okay? So if you're looking for fluid, the patient should lay on their right side, correct? Okay. To demonstrate air, because air rises, the patient should be positioned on the unaffected side. So if the patient, they're worried about free air or a pneumothorax in the left lung, right? The patient should lay on what side?
Right.
Okay. This can get confusing, guys, so just try and keep it as straight as you can in your brains. The patient must remain in that position for 5 minutes prior to exposure. Now, I told my lab groups already that I could tell you on one hand how many times I've done this on an adult. What'd I say, 2 times?
3.
Full?
Like 3.
You said 3.
3, one of those being like my test out.
Yeah.
Okay, which I basically like comped on a friend. I didn't do it on a real person. But I can tell you how many times I've done it on a baby in the NICU.
He said a whole lot.
A lot, yes. Because babies can't sit up, right? So you're always taking supine pictures on like NICU babies. So a way to give an opposing view would be a decube like this. The patient remains in the position for that 5 minutes, allows fluid to settle and air to rise. Again, same thing, guys. You'll see a lot of similarities here. It's 1.5 to 2 inches above the shoulders where the light should be. Okay. So left lateral decube, affected side up, air fluid levels. So see the side that's marked, right? That's right up. And you can see that free air right there. See where the arrows are? Okay. And then the right lateral decube with the affected side down, right? So what marker should be up here, guys, where it says up? Left. Very good. And you see these black arrows at the bottom, that's showing that fluid that's settled down into the lung. So the part position, elevate the body 2 to 3 inches if lying on the affected side. We use this with a sponge in lab. For some patients that might be on the higher fluffy scale, you may not need to build them up as much. But for a very asthenic person, you need to make sure that they are definitely built up because they will sink down into the table and you'll be clipping the apices, right? You won't be able to see it. You extend the arms over the head, a true lateral without rotation, so you may have to go down their body and make sure that their knees are stacked and that you can get their hips rotated to keep the thoracic cavity lateral. Anterior posterior surface of the chest against the vertical grid device, so don't leave a big gap, right? In lab we did our fabulous dolly dummy against the upright buggy on a cart, which was pretty easy. We supported her up with some sandbags, which was awesome, but she was pretty easy to maneuver, right? It's gonna be real life stuff where you may not be able to do this very easily on the table, and a cart might be better for this projection. Now, beds, carts, the patient might sink, so again, you'll still probably have to bring them up a little bit. The central ray is horizontal and perpendicular to the IR, and the MSP is at 3 inches below the jugular notch for an AP and T7 for a PA. Okay, so jugular notch for an AP, T7 for a PA. You guys remember how to find T7? Right?
Yeah.
Vertebral prominence. Okay. And again, exposure made onto full inspirations. On second inspiration, sorry. The structures you should see. Changes in fluid position. Presence of any free air. Affected side is in its entirety. So, the image on the bottom there. The affected side is up. You see the arrows. They're looking for that free air. Again, my critique is no marker. But you're clipping the lower half of the chest, right? So again, that might slide, especially if the patient's had other chest x-rays during this exam, that the sole purpose for this is to look for that free air, okay? So, no rotation of the patient, sternal ends of the clavicles are equidistant from the spine, same things apply just like an AP. The patient's arms are not visible in the field of interest. So you guys might have to get creative, right? If you got Granny come in and she's got really bad shoulders because she's done hard work her whole life, and this is all the more she can get them up, right? You might have to help her, a tech might have to help her, right? You might have to give her something to try and reach for above her head. You want to see the spine faintly in the vascular markings in the hilar region of the periphery of the lungs. So here is a ventral or dorsal decube. You will not need to demonstrate this in lab, right? You need to know it for the test. The patient is either prone or supine. So these are the easiest ones to do right after doing an AP chest. This is like a cross table lateral, basically. The body's elevated 2 to 3 inches, top of the IR at the level of the thyroid cartilage. So see how it's kind of up by his neck? You should have light up on his neck in this image. Remains in position for 5 minutes to evaluate fluid to settle and air to rise. A true prone or supine position without rotation is needed. The affected side against the vertical grid device, arms above the head. The central reg is still perpendicular to the IR, and it enters at the level of the MCP 3 to 4 inches below the jugular notch. For the dorsal and ventral DQ is at T7. Exposure made after the second full inspiration. Change there. So some things that you should see are, again, fluid position change. And the entire lung field, including the anterior and posterior surface. Right, that's why you gotta build them up a little bit. If you're missing the back here where those arrows are, that's no good. Upper lung field's not obscured by the arms. Make sure you're trying to get those arms up out of the way. No rotation of the thorax. T7 is the center of the IR. And you still want to see those vascular markings in the hilar region. Okay. You have to bear with me because I don't have my notes, so I'm going to do the best I can here. This demonstrates all the following except what? B. Which still shows swelling for soft tissue neck, right? So it's B, odontoid displacement. Odontoid. Oh, okay, here, hold on. Not good yet. So, you haven't learned this yet, but odontoid is part of your spine, your cervical spine. That's what that's talking about. This would not be the proper projection for odontoid displacement, like after a fracture. All right, what about this one? What does it show except? a foreign body here, right? This is soft tissue neck. You need that trachea air filled, right, to give some contrast.
Would it be E as in dog?
Yeah, because it's not showing an opacified pharynx, right?
Yeah.
What's opacified mean? There should be no movement for sure, right?
Well, yeah, obviously, but I have no idea what that means.
Okay. So, in that case, guys, if there is something you don't know, and I'm not answering you right away, or write yourself a little note, like, write out the word. Because there's gonna be a lot of terms you're not familiar with at all, okay? What is this projection position and anatomy demonstrating? Very good. Why did you say C?
The clavicles are
Very good. What is this projection? Okay. Right, it's right side up. You can see the spine. Where's the position of the spine? Look at your landmarks, right? This was a left lateral decube. Where would the spine be? Wouldn't be at the bottom of the image, would it?
It would be in
It would be in the middle, right? Exactly, Lisa.
I was confused because I was thinking lateral, but looking at that picture.
Yeah. Okay. What is this one? Alright, this is where I confuse myself, sorry guys. So left side's up, so the right side's down, so right lateral decubitus, right? Yeah? What is this projection? It is A. You said B. Okay. Why is it not B? Remember our hanging protocols.
But I thought in PA it's supposed to be like the markers are supposed to be flipped.
Right, but you're looking at that image. So the right is on your left.
Isn't that AP too? Like
It
how
looks AP because you're looking at it as an
So then how would you
AP. That's
tell
what's
that?
confusing. So if this was AP, this would actually be flipped.
The aortic arch.
Not the position.
Oh,
Yes.
see, I do it all the time.
Projection.
Yeah, projection is flipped.
Not the
Does everybody
position.
understand that?
Position is AP, projection is
I'm still missing why it's PA, not AP.
Okay.
Because it's
Like,
like.
So-
defining characteristics of why it would be PA instead of AP.
So this is got a right marker on it. Remember? Hanging protocol.
Got that.
You're looking at it. Okay? So this is how a PA is hung. The right is on your left, the left is on your right. Not the actual projection.
Right, but this is also how an AP is done.
It actually should be flipped.
I thought that's how it is for PA. I don't know. I
In
found
the
this
boat,
picture.
it's literally the exact same picture and it says AP.
Well, then this is a trick question for you guys, isn't it? Oh, okay. What do you, what's different here? Everybody got their book?
Yes.
Go to 120.
Just the clavicles are lower. Well, that's flipped, but
Oh yeah, but that's for PA.
yeah.
These are electronic. Okay, so. Everybody at 120?
Yes.
Okay, so 120, when you're looking at this, right, on an AP, you look at those two images, the right will be like it's supposed to, right? Your marker should look how it's supposed to. If it's a PA, it will mirror image flip your marker. Okay?
Okay, so.
Everybody see that?
So it should,
Right, so this is an AP.
okay.
And the
But if
PA,
it
it
was
looks
split,
like
it
the
would be PA.
clavicles are.
Oh, we're not talking about the clavicles. I'm just
No,
looking,
I saw what you were talking
Yeah.
about.
let's just focus on that. So, this would be a PA if that right was going
The opposite way.
the wrong way. Right, okay. It is.
It is,
You're
that's
right.
what we just said.
Okay.
Yeah.
So
I did. No, I corrected myself. That is an AP. Sorry.
Okay.
Okay, what is this one? C. Everybody sees that one, right? Awesome. What are we missing on this?
Marker.
Marker.
And we don't use digital markers. The last one had a digital marker.
This one has a digital marker too, so we can I can't talk. Country. No,
I
not
can't
this one.
either.
Saying it. What is this one, guys? The left
That's,
posterior oblique.
oblique, left lung.
LPO.
LPO.
Yep. Depends on if it's anterior or posterior.
I think posterior is when it's closer, right, is what you're trying to look at.
I believe so.
Like, if you wanted to see the left lung, you would do it posterior oblique.
I don't know. You have your book open. Look it up. What are you asking?
Yeah, I was just like, I got the AP oblique and it's LPO, but it's a left lung or right lung. That's what I was trying to figure out, 'cause it's got the left marker. So it should.
That was the
right
one,
lung
me and
instead.
Alexis were kinda confused about that too.
Was
So
that-
we
Like,
don't
that
know if
should
the
be
marker's
right lung
wrong.
Okay, what are you asking? What are you looking for here?
I guess we just confused ourselves because the marker was like, it was right, but like posterior, we're like, does it have to be flipped? But then I think I just answered my question because I think it's only flipped in PA.
Right.
But it's, so yeah, I just answered my
Their
question.
left
but-
side is
That's
closer to
what
the grid, cause like when you do the lateral,
Yeah.
like the regular lateral, if it's a left lateral, you mark it left, right?
If it's a left lateral, you mark it.
Yeah, so if it's a left oblique, posterior. then
Mark
you
the
mark-
side that's down.
You always mark the side that's touching the board.
Yeah,
So the left side is touching the board,
Yep.
but is it the right lung or the left lung?
So what's this one?
That's also, that's an L,
LAO.
LAO.
This is an LAO.
But again, is it a right
Yeah,
lung or a left?
so this is an LAO. Will you answer your own question? What you just asked?
Well, no, that was because I get confused on whether it's left lung or right lung that you're looking at.
Oh, okay.
It's LAO.
So
but
it's,
there are two
here's
LAOs in
the
one
grid, right? Sorry, I'm trying to think in my own way. This is my left, right?
Yes.
Okay.
Okay.
that would be, you'd
So
be
that would
looking at
be
the left
left.
lung.
Right side
Left
interior.
Because it's
posterior
PA, so you're
oblique.
looking at the side that's farthest from the
Yeah.
grid.
Right, because you elongated all of the right lung,
But
right?
if it was AP, then it would be the left lung.
Yeah.
So we're looking at the left lung.
No.
No.
No,
right
you're looking at the
lung.
right
The
lung.
right lung, okay.
The anterior ones, so.
Okay.
So the one before that.
Write your question down. Answer your question, right? Everybody write your question down. So you don't confuse yourself and then you don't confuse other people around you. But everybody understands why this is an LAO. And it's a posterior.
Yes.
Okay. I see Tiffany shaking her head. Why not?
There's so many people talking at one time, it just confused the crap out of us.
Okay, that's what you're gonna have to kind of mitigate, right? Know it how you know it, because everybody knows it differently.
Okay,
you're looking, your focus, what anatomy you're really focusing on is the right lung.
So it's RAO.
No, it's LAO.
It's LAO.
It's flipped for PA. Like if it was
So
AP,
see
then
how
would
that
be-
left marker looks backwards up there? That's how you know that it's a PA. Okay, so provided that this is a good image, right, that they've appropriately marked the correct side, you know that they're marking the side that's down, the side that's closest to the IR. So then you say, okay, so I know that the patient's left side is there, which elongates the right lung, right? That marker's flipped, so that's a PA, so posterior to anterior. So then that's telling you that it's a left anterior oblique, sorry. Okay, so the anterior surface is facing the IR. Okay,
But again, are we
and
looking at their left
Tiffany,
lung?
come find me after class too, because, and anybody else that this confused the heck out of, because there is a really good way to remember this. Okay, let that go. These are all like opposites. Okay, and I'll explain that after class if you want. Anybody else that wants that explanation. Okay. Name the projection.
A.
Do we know without a marker?
That's a good question.
I was about to say, I think I found this one.
But look at the ribs.
That one's
It's AP,
I think it's AP.
I think it's AP too.
because what is it, you can count like 10 posterior ribs down.
Well, and remember that the ribs look a little more flattened, right?
Okay, I found the picture in the book, and it says PHS during inspiration. And it looks exactly like that. But I thought it would be. No idea. On page 105. If the heart's on the left side, then that would be.
105?
Yeah.
105 figured 3.29.
Okay, that's not a very fair picture, and they cropped out the right marker, because that's not the same image. All right, we'll go back to number 10. Which chest projection position should be performed to demonstrate a pleural effusion in the right lung if the patient cannot stand? What did you say again? D, right, correct. So you're gonna turn them on the right side?
pleural effusion is fluid.
Yep.
Fluid goes down.
What's a pneumothorax?
Air. Air goes up.
Free air. Which chest projection should be performed to demonstrate a pneumothorax in the left lung if the patient cannot stand?
Also decent.
Very good. What type of CR angle is required for the AP semi-axial projection of the apices of the lungs?
B.
Read that question again. What type of CR angle, central ray guys,
Oh.
No
A.
way.